Yes, hello. John Zdral here from Fullerton, California, and I'm an ophthalmologist in private practice. And we're here to talk about the ring that we've developed for MORCHER and FCI Ophthalmics. And the ring is designed to help stabilize the toric lens. So we thought of this concept about 8 years ago and developed some prototypes. And the design was such that it was made to hopefully kind of help stabilize and hold in place the toric lens so it wouldn't rotate out of position. So this new design is kind of a takeoff on previous CTR rings, but more specific for making a toric lens stay in one position and not rotate out of place such that you would have to go back and reposition it. So the design was made with these indentations that are about 1.5 millimeters in size, and they approximate the size of the haptic at the terminal bulb. So they would hopefully catch the haptic and hold it right in position where you place the toric lens in its final resting place. And we did some studies then, specifically at the university in Utah, Salt Lake City, where we did tests on cadaver eyes and with Miyake views. And we did studies to test the tension and strength of the ring and holding the lens in place. And we found that it was very significantly effective at holding the lens in place for toric lenses compared to no ring or compared to other CTR rings that weren't designed this way. So based on that, we did publish a paper then in the journal that verified these results, and it was published a few years back to complete our study. At that point, then we went to the FDA for approval, and the FDA approval came through in the last few months that allowed us to then start using this ring. And the ring is preloaded, which is nice because we've for many years had the load rings in place also, which is a bit more work, but the preloaded platform is so much easier. It goes in so smoothly and easily. We've tested these rings now and started using them on patients, and we found it to be very effective. So the toric lenses seem to be stabilized more. When you test the lens in the eye at the end of a case, you can see that the positioning is such that it seems like it's very much locked in and seems like it's holding steady. So we're very happy with the result and hope to use them on a regular basis. Yeah, as far as surgical pearls, really, if you've used CTR rings, this is very similar to what you've done already. And I think there's no learning curve to using this type of ring. It goes in smoothly and easily, and as easy as any other ring I've used. In fact, the tension on this ring is not so great that you have to guide it in place. You don't have to use the eyelet to guide it or any other special technique, although you can if you want to. It does have the eyelet. But I found that just dialing the ring in is so easy that you don't have to really worry about any special techniques other than just dialing it in and using it. So really, with this technique, you don't have to change your method at all for putting in a toric lens. The markers that you use traditionally are fine, and you could just use the same alignment techniques and markers that you've always used. So, and the ring, ideally you put it in after the cortex is out, but I like to put it in, of course, before the lens is in. So then you put the lens in and you can guide the lens into position and kind of walk it around. The lens will tend to stick a little bit more in place, so you have to, I call it walk it around, where you use the irrigation aspiration port to move the lens carefully back and forth with suction to kind of pull it towards the center of the capsule, and you can adjust it in steps that way where you get to the final resting point. It works very well. Well, as far as the endpoints, now in the studies, these were done on cadaver eyes and Miyake views. But as far as long-term studies, we don't have any data yet because we just started using the ring in the last few months. But I can tell you anecdotally that it seems to be working very effectively on the patients I've used it on already over the past few months of using the ring and using other rings too, including the Henderson, which we used for many years. for kind of the same kind of concept in the past. Well, I would say that as far as refractive post-op, you're going to have a more stable lens, a better lens positioning. You're going to have a more stabilized capsule. And I think that as far as the accuracy of your toric corrections, it's going to allow you to really hit the spot and be as perfectly accurate as possible. Once you put a lens in a certain position, it's going to stay in position, because if it rotates, as you know, 10 degrees or more out of position, you've lost a significant amount of your correction, especially with high power torics and highly myopic eyes and so forth. You really want that lens to stay in the right spot. Going back to have to reoperate is just, while it's not a major surgery, it's inconvenient for the patient and the surgeon as well. The patients just don't like to hear the idea of or approach that you have to reoperate on something that sounds like a failure in a way. You just want to avoid that in the first place if you can.